Hello, and welcome to today's webinar, CMS Proposed Changes to Meaningful Use. Today, we'll provide insight about the CMS Proposed Rule Changes to Meaningful Use and the impact on hospitals. My name is Brent Birchfield, and I'm Chief Systems Marketing Specialist. In just a moment, we'll be joined by our presenter. If you have any questions that you'd like to submit for the Q&A at the end of the webinar, click on the icon with the question mark and type in your question at any point throughout the webinar. We'll gather these questions and try to address as many as time permits. At the end of the session, if we don't get to your question, we will follow up with you by email to address your questions. We will have a recorded version of this session so you can view the material or share the presentation. I will distribute the recording of this event to all attendees. And now to kick off our presentation is Dr. Robert Hitchcock. Dr. Robert Hitchcock joined T-System in 2008 and is responsible for developing and advancing T-System strategy for key industry and regulatory issues such as meaningful use, ICD-10, population health management, and care quality. In addition, he leads the development of T-System's physician-centric and freestanding emergency center solutions with a focus on clinical quality and system usability. And now to kick off our presentation is Dr. Robert Hitchcock.
Thank you, Bryn, and good afternoon, everybody. It's a pleasure to have you join us for a discussion on the meaningful use proposed changes for 2015 through 2017 for hospitals. Today, we're going to go through what's been proposed by CMS to update meaningful use for the current year, and up until Stage 3 is intended to come into play mandatorily in 2018. So between now and then, what does CMS want to do to make meaningful use easier? We're going to talk about a few things today. We're going to talk about what brought this change around, the proposal, what the goal of those changes are. We're actually going to go through the proposed changes, both changes in the time frame or the types of reporting periods, and each individual measure related to hospitals today. And we're going to talk about the implications for hospitals by year and by stage. What does it mean for folks this year in Stage 1 and Stage 2? And then talk about next steps. What's the follow-up from here, or what happens from this point on? What brought about the meaningful use proposed change rules to 2015? Well, 2014 was a very rough year for meaningful use. It was the first year of Stage 2, which was already delayed, and it really didn't go smoothly. Many of the vendors couldn't meet the Stage 2 demand. Either they didn't have a certified solution in time, or they were unable to get the upgrades out in a timely fashion to support their facilities, their clients, meeting meaningful use in 2014. Many eligible providers really failed to report. The numbers went from really substantially large numbers of eligible providers to extremely small numbers of eligible providers being able to meet meaningful use. A lot of hospitals and eligible providers sought hardship exemptions that were offered in 2014. Which were primarily vendor hardships. So CMS responded in 2014 by reducing the reporting period to 1 calendar quarter instead of 1 full year for those folks outside of their first year of meaningful use. This was really to help folks try and get those systems in place and meet meaningful use. As a result, there's been a lot of criticism of the meaningful use program. Congress has questioned the program and CMS directly. Why have we spent a ton of money and not seen results, and why are people dropping out of the program? ONC has been heavily criticized for failure to solve interoperability issues. Not all of this, of course, is their fault by any means, but the two organizations that are part of HHS that are responsible for meaningful use have come under heavy fire. Vendors have come into fire as well, especially the large vendors, even some of them in front of Congress, for failing to play nice in getting meaningful use out there. Professional organizations have demanded relief on behalf of their constituents, fairly widespread. They've called and said, we need to really do something for folks. And eligible providers in really massive numbers have largely said, listen, this program is way too difficult for us, it's too costly, we're going to take the hit on our Medicare reimbursement, and we're not going to participate in meaningful use any longer. So CMS and ONC got together and proposed some changes for this time frame. These changes, however, are only issued by CMS because they only affect the actual program, not the vendors and the certification, but what hospitals and eligible providers need to do for meaningful use in the next couple of years. And so the goals of these proposed changes were to give hospitals more time. They realized that even that one calendar quarter in 2014 didn't work well enough to get folks the time they needed to not only deploy those certified solutions, but to develop their processes, to do their dry runs, and to meet meaningful use. They really wanted to simplify the measures and the program, felt it was far too complex the way it was being administered with core and menu measures and all these other things that we'll discuss here in a moment. They wanted to align the proposed Meaningful Use Stage 3 program and the measure approach with what they've proposed here in Stage 2. You may recall that early this year, CMS had said they were going to give relief in 2015, and they were going to do a couple of things. And a lot of folks were wondering why it was taking so long for them to put out those proposals. Well, in fact, I believe that it was largely due to the fact that they wanted to put the Stage 3 proposals out there in the way they were going to start approaching meaningful use, and then put out these changes, because these changes very much mirror the approach in Stage 3, and I'm going to talk about this in just a moment. Of course, they want to increase or retain the program participants to keep the vast majority of eligible hospitals and providers in the meaningful use program, and much of it is also, of course, save face. So let's talk about the nitty-gritty behind this, the proposed changes. What has CMS proposed for the change of reporting for eligible hospitals, including critical access hospitals? Well, the single largest proposal is that hospitals will be moved to the calendar year. Up until now, eligible providers had been on the calendar year. Their reporting period was January to December, and hospitals were on the federal fiscal year, with their reporting from October 1 through September 30th. CMS has decided they really want everybody on the same reporting period, and this will become evident why here in just a moment as we talk about some of the measures. But this is a real help for 2015, because what this means is that the current 2015 meaningful use year for hospitals is now extended to December 31st. That's 3 additional months to meet meaningful use this year. And from here on out, it will be on the calendar year, so January to December. Critical access hospitals, take note, 2015, of course, is your last year in general to get reimbursement for implementing certified systems and the costs that you have. You now have 3 more months in which to meet meaningful use, which gives you a longer time frame. You can still be out looking for some certified systems and getting them in. So moving to the calendar year gets you 3 additional months this year. Very good news. Second good news, and really important because many of the hospitals to date have not been able to start collecting data last October 1st. There will only be a required 90-day reporting period for 2015. These are for all participants, regardless of stage or year. 90 days is it. It's not calendar quarter like it was in 2014. It is literally just 90 consecutive days of reporting, which you can couple that with the 3 additional months in the calendar year move. You really could start in October through December and meet meaningful use. So the time frame's really been pushed out. It being, May now, you do have time to go do what you need to do to be ready and collect your data before the end of December. Now for the real heart of the matter, we kind of knew those other proposals were coming. CMS did call them out earlier this year, and they were presented exactly as they said they would be. Now for the really big change, and that is the meaningful use measures. You'll recall the meaningful use program currently has required measures and optional or menu measures. You had to meet all of the required, and you had to choose half of the menu measures. CMS is proposing to change that to reduce the total number of measures to 9 and to make them all required. You will see that they've removed some of the even currently required measures for Stage 2, like EMAR. It no longer exists in these proposals. These 9 measures are largely identical between the eligible provider and the eligible hospital. There are a couple of small differences. This presentation is really on hospitals, but we will provide to participants the eligible provider requirements as well. And you'll want to pay attention to this presentation, even if you're interested in EPs, because the large number of them do overlap. So 9 total measures for hospitals, nothing optional. You must just meet all of those 9, except in 2015, they've given a large number of exclusions, particularly for those people who are supposed to be in stage 1 currently in 2015. They're allowing a lot of exclusions on these measures, and meaningful use is about as simple now as it could possibly be. So for 2015, there's also a little one exclusion for stage 2 participants, and we're going to discuss these because we're going to go through every measure in great detail. So very important concept here, though, that for 2015, they have the concept of stage. If you're supposed to be in stage 1 or stage 2 now, you have to follow requirements according to that stage. But starting January 1 of 2016, the same measurements, the same requirements, the same thresholds apply to every eligible hospital participant, regardless of what stage you're in this year. If you are stage 1, year 1 in 2015, next year, there's no stage 1 or stage 2. You have to meet the same requirements as somebody who's been in stage 2 for 2 years now. So that said, hopefully this will make a little more sense as we move forward. Here are the 9 proposed measures for eligible hospitals: using CPOE, providing a summary of care, implementing clinical decision support, implementing e-prescribing, reconciling medications, providing patient education, providing patients electronic access to their healthcare data, provide some public health reporting, and perform a security analysis. You'll recognize all of these as current measures in meaningful use. You will recognize, too, that e-prescribing is currently only a stage 2, and it's a menu measure, and we're going to discuss what CMS has done for some relief this year in that respect. You'll also recognize that security analysis is not a certified EHR duty. That is something that the hospital does in analyzing any risks or threats to their environment and coming up with a mitigation plan. So the first 8 are those that you need to look to your certified EHR or EHRs to help you meet meaningful use for. As we go through each one of these measures, I think you'll recognize the thresholds and those types of things are very consistent with the current methodologies. So let's start and go through each one of these proposed measures. CPOE. The way the next several slides for each one of these measures are organized are the first column on the left that lists the details will be what everyone must meet starting next January. The following 2 columns will include what people this current year, what hospitals that are in stage 2 or stage 1 this current year must meet. Largely, the stage 2 folks in 2015 will be fairly identical to what everyone will be doing in 2016. There is one small exception for e-prescribing. So what does it mean for CPOE? Well, everybody starting in 2016 will have to use CPOE to order at least 60% of their medications, 30% of their lab studies, and 30% of their radiology studies. Those are the current thresholds for stage 2. So 2016 to 2017, everybody must do those 3 elements, meet each one independently: 60% meds, 30% lab, 30% radiology. This current year, if you are a hospital scheduled to do stage 2, you must meet those thresholds. Those have been stage 2 thresholds all along. If you are in stage 1 this current year only for hospitals, you must only meet CPOE for 30% is your threshold, and you can use either of the current denominators, either 30% of your total medication orders or 30% of the unique patients with a medication in their medication list have a medication ordered by CPOE. So these haven't changed from stage to stage. These are very consistent with what you would have expected to meet this current year. Please understand, though, that starting in 2016, everybody will be held to the highest standard regardless of what stage you're in this year. So let's move on. Summary of care. Also very consistent. Starting in January, everybody, all hospitals must electronically transmit a summary of care on at least 10% of their transitions of care. That is the current stage 2 requirement. So you'll see that folks in Stage 2 in 2015, that is your requirement this year. Stage 1 folks, in 2015 only, you are excluded from this measure. There's no Stage 1 equivalent to this. Therefore, they can't impose this requirement on you this late in the year. So if you're in Stage 1 in 2015, you do not have to do or meet this measure in order to qualify for meaningful use. Clinical decision support. You'll recognize this as well. Starting next year, hospitals must both implement 5 clinical decision support rules, as well as have drug-drug and drug allergy interaction checking on for the entire reporting period. You'll recognize this as a Stage 2 requirement. These are the same requirements, same thresholds, et cetera. So folks in Stage 2 this current year, same thing, 5 CDS rules and interaction checking on. Stage 1 folks, for 2015 only, it's 1 clinical decision support rule and interaction checking, the same things that you would have been anticipated and expected to meet for Stage 1. So nothing new here, but again, this Stage 1 relief only lasts for 2015. Everybody's going to be doing the more stringent requirements in 2016 and 2017. E-Prescribing. Here's kind of a unique one because it does exist currently only in Stage 2 as a menu measure. So in 2016 and 2017, all hospitals will be expected to electronically prescribe at least 10% of their permissible discharge medications. Stage 2 folks in 2015, you can exclude this measure. If you weren't planning on doing e-prescribing this year, they're not going to make you do e-prescribing this year. You can choose to either meet that measure or exclude it by attesting that you were not planning on using this anyways. Stage 1 folks, this year alone, you are fully excluded from this measure because there is no Stage 1 equivalent. So you don't even have to worry about choosing to exclude it. You get excluded automatically. So in theory, for 2015, no hospital needs to meet this measure. Medication reconciliation. Again, this will look familiar. Starting in 2016, all hospitals must perform med reconciliation at least 50% of inbound transitions of care. Stage 2 folks in 2015, you'll recognize this was a requirement, a core required element. So yes, you are expected in 2015 to perform MedRec on 50% of your inbound transitions of care. Stage 1 folks, for 2015 only, you can choose to exclude this. This was a menu measure for Stage 1. If you were not planning on meeting this measure for Stage 1 this year, you can choose to exclude it. Again, please recall, starting in 2016 and through 2017, everyone will have to perform MedRec on 50% of inbound transitions. But Stage 1 folks get a break this year because it was never expected that they meet MedRec as a requirement. They could have as a menu measure, but you can choose to exclude this, and you're going to see this on a few more elements here. Patient education, very similarly, this was a menu measure in Stage 1, a required measure in Stage 2. So for everybody in 2016, 10% of your unique patients get educational materials from your certified EHR. Stage 2 folks, you must meet that measure this year. Stage 1 folks, since it was a measure, a menu measure for Stage 1, you can choose to exclude this just the same as MedRec, but only for this year. Patient electronic access. Here's some additional relief. This is the view, download, and transmit requirement. They've simplified this to about as simple as you can get. So starting in 2016 and for 2017, all hospitals must provide at least 50% of their discharged patients with online access to their information within 36 hours of discharge, no different than what's required today, and have at least one patient view, download, or transmit their information during the reporting period. Gone is the threshold requirement to have a percentage of your patients do something with their information after they've left the hospital. You only have to have one do it. That seems like a no-brainer. So Stage 2 folks in 2015, since you have the full view, download, and transmit required of you now, you will be expected to meet both of these measures, provide at least 50% of their patients online access within 36 hours, and have one of them do something with it, just one. Stage 1 folks, for 2015 only, you are already required to provide at least 50% of your patients with their information. You are continued to have to do that, but you don't have to have that one patient do something. It's not much of an exclusion, but it is an exclusion. So you only have to worry about getting your patients access to their information, not if any single one of them does anything. You'll also notice that one of the requirements to show that you can do this and exchange and do other things like that, not there anymore. These are there's only two portions to this measure: give patients access and have one of them do something. Public health reporting. For public health reporting, there are some significant changes here. What CMS was hearing was that folks were having a difficult time demonstrating for stage 2 an ongoing and continuous submission of data to public health agencies. And they were having a hard time doing that for a variety of different reasons, from technology reasons to not having someone to send it to just, hey, we didn't have enough time to test, these guys are busy too, a whole bunch of different reasons. So there are two major concept changes here. The first is that there's flexibility given in the types of reporting that you do. You're no longer going to be required to do immunization or syndromic surveillance. You can choose from the different types of reporting capabilities out there, including clinical data repositories. You can choose 3 of those 6. That will be the requirement in 2016, that you are working on at least three of the 6 reporting types. That stage 2 folks, same thing this year. You need to have three things that you're involved with. Stage 1 folks, it's only 2. Now let me explain what actively engaged means. This is the other great break for the next few years. Actively engaged means that you have to show your willingness to do something with this data by one of 3 things: either a completed registration with the receiving agency to submit the data, that you're in testing of submitted data, or that you're in production. You're actively sending that production data, the real-time live data. CMS has changed this to active engagement because they realized that folks were demonstrating the willingness, and they have actually contracted with a lot of these third parties to send them data, but they didn't have time to do the testing. And it wasn't the hospital's fault. The receiving agency is just as stressed in their technology. So CMS would like to see that over time you show progression. Of course, if you've registered to submit data, they want to see that at some point you're testing and validating it, and then at some point you're actively sending it, but they haven't said that you have to show this progression from year to year. So back to public health reporting. For this year, if you're a stage 1 hospital, you must show that you have active engagement to submit data for at least 2 of the 6 reporting measures. That means complete the registration, or do some testing, or actually be sending data. So that's a break. It's a break because it just shows your willingness. The stage 2 folks, an even bigger break because you were expected to be showing continuous and ongoing submission of data. You don't have to do that now. Just show active engagement on at least 3 of the 6 reporting measures. Back to 2016 and 2017, everybody will have to show active engagement on those 3 to 6 reporting measures. Those are the measures, and those are the only 8 things plus your security analysis that hospitals will need to do between now and stage 3. That's the proposal from CMS. Nothing will get worse than this. What does this mean? Let's go back, though, and now let's take a look. If you're a stage 1 hospital in 2015, whether it's year 1 or year 2, doesn't matter. If you were supposed to do stage 1 in 2015, what does 2015 mean to you? Well, first of all, it means that you have until December 31st of this year to collect the data, and you only need to report on 90 consecutive days. That means you have 6+ months in order to get 90 consecutive days done. And you only need to do the following 5 things to meet meaningful use in 2015. Use CPOE to order at least 30% of medications, or order medications on at least 30% of your unique patients with a medication in their medication list. You need to implement 1 CDS rule and your interaction checking. You need to be actively engaged for public health reporting for 2 measures. And again, active engagement could mean nothing more than an agreement to send data at some point in the future. And you need to provide patients online access to their medical records at a threshold of 50% of the discharges. Of course, you do need to perform that security analysis on a yearly basis. That's it. That is stage 1 for you this current year. About as simple as you can possibly get. And those are the only 5 things. Remember, you have exclusions, or you can claim exclusions on all of the other measures this current year. Now, that does not apply next year. This is only a snapshot for stage 1 in 2015. Remember that in 2016, and I can't hammer this home enough, the idea of stages goes away. Everybody is meeting, all hospitals are meeting the same requirements. If you're a stage 2 hospital this current year in 2015, you have to do more, as to be expected. But you have until December 31st to collect your data. You only need to report on 90 consecutive days worth of data. So that's your 6+ months worth of time to get 90 consecutive days in. Your measures: CPOE for 60% of med, 30% of lab, and 30% of radiology orders. 10% electronically transmitted summary of care. Implement 5 clinical decision support rules and your interaction checking. Perform med reconciliation on 50% of your patients. Provide patient education to 10%. Provide patients access to their records at a threshold of 50% and have 1 patient do something with it. Be actively engaged for public health reporting on 3 measures. Again, active engagement can mean anything from contractually agreeing to send data to future time to live production data. And perform your security analysis. You'll notice that there's 1 element on here, and that is the one that you can claim an exclusion to. That's e-prescribing, not required of stage 2 hospitals in 2015. And then lastly, going back to that idea that stages really disappear in 2016, here's what 2016 and 2017 calendar years look like for all hospitals. Collect your data for a full year from January to December, and meet all of the measures: CPOE, summary of care, CDS, e-prescribing, med reconciliation, patient education, view, download, and transmit or patient access, and public health reporting in your security analysis. Along with this webinar, we're going to give you a cheat sheet, if you will. It's a look at all of the measures for hospitals, what it looks like for 2015 based on stage, and what it looks like in 2016. It's really each of those individual slides put together. We'll also be providing one for eligible providers as well. So what's next from here? So there's relief out there. Currently, this is a proposed rule. The way the rulemaking process works is they propose a rule, they put it out for what's called public comment. Anybody can comment on the rule. They can comment fully in favor, they can say they hate it, they want certain things changed, they can ask questions in comments to say, hey, it would be really great if in the final rule you could clarify what you mean by X, Y, or Z. That public comment period is open until June 15th of this year. And we should expect that the final rule will be issued somewhere roughly 60 to 120 days after the public comment period ends. Earlier, maybe, but in general, that's a rough time frame. There's no time frame that they're held to under a standard necessarily, but look for it roughly 2 to 4 months after the public comment period ends. I know that seems like a lot because that's going to push us into much later this year, but the good news is it is highly unlikely, it would actually be unethical in my opinion, but highly unlikely that the final rule will require anything more from a hospital than what was proposed. Now you'll notice that I didn't cover things like clinical quality measures. They really didn't make any significant changes to clinical quality measures, to penalties or other things like that. They had to adjust time frames and when people will have to report because they adjusted the reporting period. So in the past, they used to require that your year as a hospital was over in October, you had to report by November 31st. Of course, they had to change that language because they couldn't require you to report by November, the end of November, November 30th, if your year wasn't even over yet. So they did a lot of tidying up and cleaning, but really no other substantial changes. Not to say that those changes couldn't come in the final rule, but that what's in the final rule will not be more stringent than what is projected here. It is almost assuredly, and of course I never say 100% with anything in the world, particularly the rulemaking process and legislation, but hospitals should be looking at this as the way they will have to meet meaningful use in 2015. and it probably will only get better from here in the final rule if there are any changes at all. More likely than not, this is the way the final rule will come out. So if you would like to comment on any of these, if you'd like to comment as a hospital and go, hey, listen, we thought we had a few more years to not do e-prescribing. It was a menu measure. We don't want to make that investment. It's going to be taxing on us as an organization. And you want to say, hey, let's not put that one in here. If you want to make that comment or any other comment on this final rule, I've put up 2 ways to do that. There are more, but one is online at regulations.gov. And if you search this particular regulation from CMS, and I put it there in quotes for you, it will come up. And once you find that regulation in the search, over to the right-hand side, you'll see a Provide Comment button. You can click that button, and then you can either upload a document or put text right into a text field and provide your feedback that way. If you want to respond by mail, you can do that as well. The regular mail address is on the screen here. There is a different overnight mail address and actually a different if you're going to a different address if you're going to be providing it by courier if you happen to be in the DC area. But this is the regular mail. If you are going to send it by regular mail, make sure that you give it plenty of time to get there because it has to be there by June 15th at 5 p.m., not mailed by June 15th at 5 p.m., but at the CMS facilities by June 15th. So if you'd like to comment, please do. I would also encourage you, if you have a particular comment that you'd like to see T-System represent in our comments to CMS, because we will more than likely provide public comment on this, largely in favor, then go ahead and please send that comment to me directly. It's bhitchcock, HITCHCOCK at tsystem.com. Or you can provide it to our general mailbox at info@tsystem.com, and it should make its way to me. But bhitchcock at tsystem.com. Let me know if there's anything you'd like to have us in comment for you, and we will go ahead and do that. Now, I realize I apologize. I'm right at that 30-minute mark, but we would like to take some questions. And we're going to open it up to questions at this point. And I thank you all very much for attending. I'm almost sorry that we have to have so many webinars on meaningful use, but the changes seem to come fast and furious nearly every year now. But these changes, I think, are for the betterment of everyone. It makes the program much easier. And it does give us an insight into Stage 3. Those Stage 3 proposed rules are out. We will likely be holding a webinar on those as well. Please know that the Stage 3 approach to meaningful use is much like the proposal that they've offered here, in that as of 2018, everybody will be playing the same meaningful use game with the same measures, the same thresholds, and all those measures will be required. So one other quick comment. I did not go into all of the depth on some of these measures. There are instances of hospitals being excluded from certain measures, particularly the electronic access measures, when certain conditions are met. So for small hospitals in very rural areas with very poor penetration of the technology services that are necessary for patients to get access, all of those exclusions still exist in this program. I did not go through those in detail, but please know that if you had the opportunity for exclusion before because of a technology limitation, or say eligible providers on e-prescribing, if you're not prescribed doing more than 100 prescriptions in the reporting period, all of those exclusions generally still exist, and I didn't mean to imply that they're not there. So please, you may want to look through that rule yourself. Certainly look through the final rule as it comes out for any of those last-minute details. I'm also aware that CMS will be also holding a webinar on this. It's a joint CMS-ONC on the 11th. And if you haven't been invited to that, please go out and take a look for that online and see if you can get registered. And hopefully, if everything goes well, you'll hear the same from them that you heard from me. So I thank you very much for your attentiveness and for the very large number of you attending this webinar. I hope that you found it useful. We'll open it up for questions, and when we do send out this recording, we will also send out the cheat sheet for eligible providers and hospitals that talks about these measures. So thank you very much again.